V1 and AVF, they lie in opposition. V1, V2 lie in opposition to V5, V6. If something positive is happening in lead 1, negative will happen in AVF. Positive happens in V1, V2, negative happens in V5, V6. Now let us consider first inferior wall MI. Now this is the inferior wall MI, and we are focusing on lead 2, lead 3 and AVF. And it is just a common sense thing, if there is infarction occurring, the positivity of that area is decreasing. Okay, so you just say lead AVF has become negative, plot it at minus 90, and lead 1 has to become positive. Okay, because current cannot travel in both directions, it has to travel only in one direction. Lead AVF becomes negative, lead 1 becomes more positive. There is a left axis deviation, and the sudden axis shift to left side, you should always think of inferior wall MI. Likewise, in lateral wall MI, in anterior MI, lead 1 and AVL, V5, V6, they are becoming less positive. So you plot lead 1 at 180 degree, and automatically opposite to lead 1 is AVF. AVF becomes more positive. We can draw 2 plus signs at AVF plus 90 degree. So the axis is now lying in right axis deviation quadrant from plus 90 to 180 degree. So in short, in anterior MI there is RAD, in inferior MI there is LAD. So axis is so important. That is why always when you look to interpret the ECG, rate rhythm axis. Never bypass these steps, and you will not miss an MI also. Okay, so now we come to the ECG findings in acute myocardial infarction. The first subtle thing that happens is there is merging of ST segment with the proximal limb of the T wave. You will find it difficult to say, sir, the T wave is starting from here and ST is ending here. There is merging of ST ending and beginning of the T wave. And then you will see hyperacute T waves, very tall T waves. They might even supersede the R wave amplitude. And there will be ST coving. Coving is very important to pick up because it signifies that acute injury is taking place. That is the time you have to intervene. That is the time you have to give thrombolytic therapy. You can thrombolize the patient with whatever agent you are using in your hospital. You can give streptokinase, urokinase, tenecteplase, RTPA, whatever you want to give. But coving is there, you thrombolize. Coving is not there, probably the thrombolysis will not help. Sometimes I have seen people, they will just say TROP-T is negative, mild coving is there. No, you have to treat the patient, you have to give thrombolysis, because the same patient's ECG after 1 hour will show coving has subsided, it has come down, T has inverted, and then after few more hours the Q wave develops. So by that time we have lost that precious window period. You have to give thrombolytic therapy in the first half hour or 1 hour, maximum up to 6 hours. And you can give thrombolytic therapy up to 24 hours also, because there are a lot of studies which have shown that it helps. And if the patient is stable, you can give thrombolytic therapy, there is no harm. So in the initial stages, you will see ST coving, merging of the ST with T wave and tall T waves, hyperacute T waves you call them. This is acute MI, injury taking place, you have to intervene. And then after few hours, the ST comes little down and T starts to sag. It might become flat first, you might see a flat T wave, and then the T wave inverts. Then after few hours, the Q wave develops, a pathological Q wave develops. What is a pathological Q wave? It is a Q wave which is more than 0.4 seconds in duration and more than 1/3 of the R wave amplitude. So that is a pathological Q wave. Normally also you will see Q waves, and in the lateral leads you will see Q waves, which will denote depolarization of the interventricular septum, and you should not confuse those Q waves with the MI changes. So these are the changes that you will see in a typical classical MI. Then in inferior wall MI you might have posterior wall MI also, where you will find tall R, tall T in V1 and sometimes in V2 lead also. And you have to keep this ECG in front of the mirror and see the tall R, it will look like Q wave, and the T upright will become inverted T. So there is a mirror image in posterior wall MI. Similarly, in right ventricular infarction, you have to look for ST coving, ST elevation and T wave changes in V3R, V4R. There is a cyclone going outside and heavy winds are blowing and there's rain, so you might be hearing this noise. But anyway, we'll continue with our lecture. So this was in short how to diagnose acute MI in the ECG and what changes to look for and a little bit of theory behind it. Thank you for watching, and please do subscribe to our channel and like the video and share the video with your friends. Hit the bell notification icon so that you are reminded of any new videos which we upload. Thank you.